Welcome to the Explainer. Today, we're locking in on the surgeon's blueprint. Our goal here is to give you a meticulously detailed pre-operative briefing on the exact anatomy, physiology, and imaging of the biliary system. Look, whether you're scrubbing in for the operating room or you just really want to understand the intricate plumbing of the human body, this Explainer is going to equip you with the essential, hard-hitting facts drawn directly from definitive surgical texts. Okay, let's run through the game plan. We're starting with surgical anatomy, moving right into physiology, then we'll evaluate radiological and intraoperative imaging, and finally, we'll wrap up with congenital abnormalities. Let's get right into it. Section 1. Surgical Anatomy, the Master Blueprint. Now, the undisputed star of the show here is the gallbladder. It's a pear-shaped reservoir, roughly 7.5 to 12 centimeters long, with a normal holding capacity of about 25 to 30 milliliters. It's tucked snugly right on the underside of the liver in the main scissura, and we divide it into the fundus, body, neck, and infundibulum. Oh, and keep this tiny but incredibly vital detail in mind. The mucous membrane actually contains these deep indentations called the crypts of Luschka, and they sink right down into the muscle coat. To safely remove a gallbladder, mastering the local geography is just, well, it's non-negotiable. Originally, K-Lot described a triangle bordered by the cystic duct, the common hepatic duct, and the cystic artery. But in modern surgical literature, we rely on the modified hepatocystic triangle. This one is bounded superiorly by the inferior surface of the liver, laterally by the cystic duct, and medially by the common hepatic duct. So why is this distinction so absolutely crucial? Because the cystic artery almost always lives right inside these boundaries. Safely exposing this area to establish the critical view of safety is literally the cornerstone of a successful cholecystectomy. Now, check out this critical anatomical landmark, Rovier's sulcus. It's this distinct cleft on the undersurface of the right lobe of the liver. Surgeons use this to map out an imaginary boundary we call the R4U line. It connects Rovier's sulcus, the base of segment 4, and the umbilical fissure. The rule here is simple, but it will absolutely save your patient's life. The cystic duct and artery always lie ventral, or anterosuperior, to this line, while the common bile duct lies below it. So to avoid a catastrophic injury to the common bile duct, literally all of your dissection must stay heavily ventral to this R4U line. Let's zoom in on a few more microstructures and anomalies that act as major danger zones. First off, the cystic duct has these spiral folds called the valves of Heister, and it's surrounded by the sphincter of Lütgens. Then, right at the junction of the cystic and common hepatic ducts, you've got the node of Lund. That's your sentinel lymph node. But the real trap, that lies in vascular anomalies. In some patients, the right hepatic artery makes this crazy, tortuous caterpillar turn known as Moynihan's hump. It brings the artery dangerously close to the gallbladder and cystic duct. If a surgeon doesn't see this coming, they might inadvertently clip the main artery instead of the cystic artery. And yeah, that drastically increases the risk of massive, sudden bleeding or severe liver ischemia. Moving on to Section 2, Surgical Physiology, the biliary flow. Anatomy gives us the structure, sure, but physiology is where the action happens. Think of the liver as a constant, non-stop factory, excreting bile at a steady clip of about 40 milliliters every single hour. Let's trace the enterohepatic circulation step by step. Step 1. The liver produces bile, which, surprisingly, is actually 97% water. Step 2. When you're fasting, the sphincter of Oddi is clamped tightly shut. Because of that, bile backs up into the gallbladder where it is actively concentrated by about 5 to 10 times. Step 3. Post-meal, cholecystokinin is released, the gallbladder contracts, that sphincter finally relaxes, and the concentrated bile just floods into the duodenum to digest fats. Then, 95% of those bile salts are rapidly recycled right in the terminal ileum. But here is a massive surgical pearl for you. The gallbladder mucosa is constantly secreting about 20 milliliters of mucus every single day. So if a stone completely blocks the cystic duct of an otherwise healthy gallbladder, that trapped mucus just keeps building up, eventually creating a massively distended mucocele. Section 3. Radiological imaging modalities. Look, a surgeon rarely goes in blind these days. Visualizing all of this anatomy accurately is your single greatest preoperative advantage. It lets you anticipate exactly what you're dealing with before you even make a single incision. We'll kick things off a bit old school with the plain radiograph. Interestingly enough, only about 10% of gallstones are radio-opaque enough to actually show up on a standard X-ray. When they do, you might catch the classic Mercedes-Benz sign. You can see it on the left. It's that distinctive triradiate gas fissure right in the center of the stone. On the right, though, we're looking at a pretty rare finding, the porcelain gallbladder. This happens when the entire wall of the gallbladder has become completely calcified. Now, look really closely at the dark outlines representing gas that is quite literally trapped within the wall of the gallbladder. This right here reveals a true drop-everything surgical emergency, emphysematous cholecystitis. It's typically caused by a gas-forming Clostridium perfringens infection. If you spot this, it necessitates immediate emergent intervention before that gallbladder completely gangrenes and perforates. Today, the true workhorses of biliary imaging are ultrasound and CT. Ultrasonography is, without a doubt, your initial choice. It's inexpensive, it's fast, and it is 90 to 95% sensitive for acute cholecystitis. You're specifically looking for a gallbladder wall that's thickened beyond 3 millimeters, pericholecystic fluid, and the sonographic Murphy sign, which is when the patient feels localized pain exactly where you press the ultrasound probe. CT, on the other hand, is completely operator independent, and it's totally superb for staging cancers. However, it is actually terrible for simple stone disease. It completely misses about 25% of gallstones simply because they aren't dense enough to register on the scan. Speaking of ultrasound, we actually use two completely different approaches. On the left is the standard external transabdominal ultrasound. You can clearly see gallstones sitting right in the neck of the gallbladder, and notice how they cast that dark acoustic shadow right behind them. On the right, we have endoscopic ultrasound, or EUS. This technique places the ultrasound probe right on the tip of an endoscope, tracking it all the way down into the stomach or duodenum. This gives you a stunningly high-fidelity, up-close view from the inside. It makes it incredibly accurate for hunting down tiny stones that might be stuck deep down in the common bile duct. Okay, let's shift gears and look at how things build when we want to test actual function, not just static anatomy. For this, we turn to the HIDA scan, a dynamic radioisotope study. We inject a technetium-99m labeled radiotracer right into the blood. Within 5 minutes, the liver takes it up. By 30 minutes, it's being actively excreted into the bile, and the gallbladder becomes fully visible. By the 1-hour mark, we should see that tracer dumping directly into the bowel. If the gallbladder never shows up on the scan, that strongly indicates the cystic duct is obstructed, which is the classic hallmark of acute cholecystitis. And this HIDA sequence isn't just for diagnosing cholecystitis. It's a truly dynamic test of biliary function. Postoperatively, if a patient is suddenly doing poorly, a HIDA scan is incredibly helpful. It can diagnose an active bile leak into the abdomen, or it can confirm that a surgically created bilioenteric anastomosis is actually patent and flowing exactly like it should. Coming back to the CT scan for a moment. As I mentioned earlier, it might miss some stones, but it is the absolute gold standard when malignancy is suspected. Here, we're looking at a cross-sectional image revealing a large mass right at the hepatic hilum. CT allows the surgical oncologist to precisely map out the exact extent of primary tumors, determine if there's any critical vascular involvement, and spot metastatic lymph nodes. Ultimately, this scan dictates whether a tumor is safely surgically resectable or not. But what if you need perfect visualization of the biliary tree, but you want to avoid radiation or invasive procedures? Enter MRCP, magnetic resonance cholangiopancreatography. Take a look at both the cross-sectional and projectional MRCP images here. This completely non-invasive modality uses fluid-sensitive MRI sequences to map out ductal strictures, hilar obstructions, and stones. It gives us diagnostic fidelity that is completely comparable to invasive techniques, but it does it totally safely. So, if MRCP is so incredibly good at diagnosis, what exactly do we use ERCP for? Well, endoscopic retrograde cholangiopancreatography has really evolved into a purely therapeutic intervention. We take a side-viewing endoscope down to the duodenum, identify the ampulla of water, and cannulate it. On the left here, contrast clearly outlines a large stone completely blocking the common duct. On the right, you can see a tight malignant stricture. With ERCP, we don't just look, we intervene. We literally crush and pull out stones, we place stents to bypass tight strictures, and we brush the ducts to obtain vital cytology samples. Sometimes, though, the anatomy is just too altered, or a stricture is just too incredibly tight for the endoscope to pass from below. That's when we have to use this invasive alternative, PTC, or percutaneous transhepatic cholangiography. Under imaging guidance, a long, slender chiba or accruta needle is passed directly through the skin, right into the liver substance itself, and straight into an intrahepatic bile duct. This establishes drainage from above, completely bypassing the stricture, and it allows us to leave a catheter in situ to decompress the liver.
So the crucial takeaway here is knowing exactly which tool to reach for. Suspect simple stones or duct dilation, you get an ultrasound. Need to non-invasively map out the anatomy or complex strictures, you order an MRCP. If you're dealing with cancer, CT is your staging tool. To evaluate pure dynamic flow or leaks, you absolutely need a HIDA scan. And if you actually need to actively pull a stone out of a duct or stent a tumor, ERCP is your therapeutic go-to.
Moving to Section 4, Intraoperative Imaging Techniques. All the preoperative imaging in the world is fantastic, but what happens once the abdomen is actually open or accessed laparoscopically? The surgeon needs to be able to confirm the anatomy in real time. The primary method we use for this is perioperative cholangiography. A small catheter is placed directly into the cystic duct, right during the surgery, and contrast is injected. On the left, you see a gentle infusion passing without any hindrance straight into the duodenum. That is a beautiful, totally normal duct. On the right, however, we see a massively dilated duct harboring multiple stones with clearly delayed flow. To get these images just right, the surgical table actually needs to be tilted head down by about 20 degrees. This helps fill the intrahepatic ducts. And, crucially, the surgeon must meticulously ensure no air bubbles are injected with the contrast. Make absolutely no mistake, an air bubble looks exactly like a gallstone on the fluoroscopy screen, and it will send you chasing a ghost problem that doesn't even exist. Section 5. Congenital biliary abnormalities. This is the final, crucial piece of the surgeon's blueprint. Standard anatomy is common, sure, but early developmental variations fundamentally alter the surgical landscape. Relying purely on textbook normality, that is a fast track to serious surgical complications. Let's quickly trace the embryological timeline. It all starts when the hepatic diverticulum arises right from the ventral wall of the foregut. It elongates into a stalk, which forms the cholecystitis. Then a lateral bud branches off, and that becomes the gallbladder and the cystic duct. During development, tissue hyperplasia actually completely obliterates the lumen of these tubes, and they must subsequently recanalize for bile to finally flow. Abnormalities occur along this exact timeline. For example, a gallbladder hanging on a mesentery can literally twist and undergo torsion, or in about 5% of patients, the gallbladder develops a folded fundus known as a Frisian cap deformity. If you aren't expecting it, it can easily be mistaken for a pathological mass. We'll conclude the explainer with one of the most perilous variations you can encounter, the low insertion of the cystic duct. Notice how the cystic duct travels way, way down before finally joining the common bile duct. If a surgeon encounters this and aggressively tries to dissect that cystic duct all the way down to its true junction, they risk completely devascularizing the common bile duct, which leads to ischemic stricture formation. Having seen the standard blueprints, the hitting danger zones, and the embryological curveballs, the real question is, are you fully prepared to adapt your approach to the exact anatomy sitting right in front of you?